Good morning, friends. Myself, Major Dr. M. Kubeg, I am presenting you a radiation oncology time dose and fractionation chapter of clinical oncology. Is entirely focused to the residents and then a smarter radiation technologist. So let us start about this chapter. The time dose and fractionation in radiotherapy is basically a multi-fractional regime based on the radiobiological experiments initially which was done in France in 1920, between 1920 to 1930, almost 10-year extensive research on the fractionated regime of radiotherapy. And then also in this study found that the ram could not be sterilized by exposing his testes to a single large dose of radiation without skin damage to the scrotum. But the same target could have been achieved by using a smaller multiple fractions. They could sterilize also without a possible skin damage. This was the concept was picked up, and so the fractionation of radiation dose produced better tumor control for a given level of normal tissue toxicity than a single large dose. So based on the radiobiology, there was a 4R was described. First is repair of sublethal damage, reassortment of cells in the cell cycle, repopulation, reoxygenation. So I'll pick up one by one. In the repair of sublethal damage, that between the two fractions there has to be a sufficient time so that the normal tissue can repair itself and then a tumor cell get killed. That is called repairs of sublethal damage. And then we know in the tumor all the cells are not in a single phase of cell cycle. So few are there in the G2 phase, some are in the M phase, some in the G2M phase, somewhere in the S phase and G1 phase. So particularly the cells, those who are in a G2M phase, are supposed to be radiosensitive because at that phase the chromatids are widely apart, and then it can be killed by the radiation. But in the S phase, which is also called a DNA synthesis phase, whatever amount of radiation is being given, immediately resynthesis of DNA happens, so that is considered to be the DNA by resistant phase. And so that again at G0, after the multiple division of cells, the few of the cells reach to the G0 phase, that is the clonogen phase, and where the cells do not divide and remain silent. These are the cells responsible for the recurrence of a tumor. So they are also radio-resistant and chemo-resistant. So that's why we in the histology you see where the S phase fraction in the tumor, if it is higher, it is supposed to be a bad prognostic factor. And then re-oxygenation, that after the giving one fraction of a radiotherapy, one proportion of the cells, those who are oxygenated, are die, because oxygen is very important for ionization, radiation, cell killing. And the cells, those who are not oxygenated, will be in the second phase of radiation, will be move towards the oxygenated phase, so that in view of that, the fractionation regime is being practiced. There's few cells in the body, the fast dividing cells like intestinal epithelium, having a cell cycle time 9 to 10 hours. They go, and there are cells having a very long cell cycle time. Most of the difference in the different tissue cell cycle is different. Most tissue in the cell cycle is vary. Like in a prostate, as a cell cycle, almost 28 days is a doubling time. That is the slowest growing tumors that we can use the hypofractionated regime, and then it's a slow growing tumor. So in the G1, G2, M and S phase, the entire cycle is basically all the phases are fixed except the G1 phase, which vary according to the cell cycle length. So this is the phase which decide in the different tumor tissues the cell cycle length of a cell cycle. The first regarding the fractionation regime, the Standquist plot and the Ellis nominal standard system was developed. In a Standquist plot, they just consider the skin and the radiation, that the damage of a skin by the radiation, increasing radiation. You see here in this graph, there is first the skin erythema, then dry squamation, moist desquamation, and the cure of skin carcinoma and the skin necrosis in the highest dose. But in human tissue, we don't have only the cells behaving like a skin. The different cells behave like a different having a different radiobiological properties in the cell cycle. So that Standquist plot was not sufficient to justify the fractionation regime, since it was based on purely on the skin portion of a radiotherapy effect. And then the Ellis, they introduced a nominal standard dose NSD system. It's basically a simplification of a Standquist plot, and then it was required in the Ellis formula that there has to be a uniform dose per fraction and uniform number of fraction per week. And with this proposed formula was TD, total dose equivalent to NSD, n to the power 0.24 into t to the power 0.11, so that we can calculate the number of fractions required. But again, it was based on the early responding tissue. But what about the late responding tissue, which is also important? So there was a weakness in both the system, that the formula was limited to the 4 fraction to up to 30 fractions. So what about the head and neck cancer in the 70 grade 35 fraction is used? This formula was not fit. The second, based on the early skin reaction, does not predict late effects. And then the most serious criticism of NSD was that of T and N should not be constant and should be tissue specific, which I have already told you. So there is a proliferation as a factor in the normal tissue. So effect of proliferation would not be seen longer period into fractionation regime because of slower response of skin and longer cell cycle time. There are accelerated proliferation after the certain phase of first length of a fractionated regime. And to counter that accelerated population, the extra dose is required to curb this thing. In the human tissue, it has been observed it is about 4 week time. After 4 week time of a radiotherapy, the accelerated repopulation happens. And then in the mouse, it was found to be 2 weeks time. So you see here, after the 4 weeks time of the human tissue, the extra dose was required to curb this thing, because the curve becomes again getting uprise, so that extra dose is required because accelerated repopulation. See, the extra dose to proliferation is sigmoidal. All the tissue of the body does not behave like a skin tissue. In fact, the early responding tissue, like a skin, epithelium, intestinal mucosa, and sometimes tumor as well. The late responding tissue like a spinal cord. But once we should also aware of there are certain tissues, tumor, they are having a late responding, fall in the late responding, like example is melanoma, prostate cancer, breast cancer, lung cancer. They are not very early responding, or the very, the fast proliferating time, cell cycle time is longer here. So the extra dose required to counter the proliferation of a tissue will be different for early responding as well as different for late responding tissues. For early, you see here in the mouse experiment, days after the radiation, the early reaction was on 14 days and the late reaction was observed on the 42 days. So there, extra dose required to counter the proliferation. So important conclusion is drawn that a prolongation overall treatment time within the normal radiotherapy range has a little sparing effect on the late reaction but has a large sparing effect to the early reactions. A second conclusion was the prolonging overall treatment time. We can overcome early reaction but there was no effect on the late reaction. So that the formula of Ellis and Esquandris plot was further clarified and more beautifully described by the linear quadratic model given by the Jack Flower, where the effect is proportional to the dose in the linear portion of this curve and the effect is proportional to the square of the dose in the quadratic portion, that is the mainly over the late responding tissue. They're having a shouldering. So dose response relation for early and late responding tissue is described here. For early effect, alpha beta ratio larger than the late effect, that early effect, for early effect alpha dominate and for late effect the beta dominates. The alpha and beta ratio is the dose at which linear and quadratic component of cell killing are equal. So you see here the beta is in the square of the gray and alpha is only gray, so that unit is becomes a gray upon -1. If somebody asks what is the unit of alpha beta ratio, with this shape, an inference drawn if a fractionation scheme is changed in a clinical practice from many small doses to few large fraction, then you will be having a more severe late effect. That you see here the shouldering and surviving fraction of the cells in the both early responding tissue and the graph of a late responding tissue. You see the early, there is no problem, linearly, it's a linear curve, but there is a shouldering in the late responding tissues. The 2 doses given per day for 6 to 7 weeks appear to result greatly reduced late effect and more severe acute effect. That is also, you can draw inference with this. So ultimately you see the early effects, and broadly speaking, the alpha beta ratio is 10 gray and a late effect is 3 gray, but actually it is not. It's a general term given because for late effects like in a breast cancer is approximately 4 to 5. For early is different from 9 to 10 to 11 to 12. It's basically a tissue specific if you ask. It's a different for alpha beta ratio for each and every tissue in the human body. The fractionation size is dominant factor in determining the late effects. Overall treatment time has a little effect. So that we should be aware of, like you see here the early effect for alpha beta ratio in the skin 9 to 12, jejunum to 6 to 10 gray, so very low. The colon 10 to 11, testes 12 to 13, and a callus of a bone 9 to 10 gray alpha beta ratio. If you see the late effect, the spinal cord is having a very low alpha beta ratio 1.7 to 4.9, and then again kidney 1 to 2.4, lung 2 to 6.3, and a bladder, urinary bladder 3.1 to 7. So each tissue is having a different alpha beta ratio, and then 10 and 3 was given as a empirical, that you can presume this is a range of for early responding tissue and late responding tissues. So, explanation for changing the shape of a curve for early and late responding tissue. There is a two group of populations as considered as radio-resistant. One population, one is those cells, those who are in S phase, occupy a major portion of the cell cycle, is radio-resistant. As I told you, why it is the radio-resistant phase. And then after the multiple proliferation, few of the cells move in the G1 or they landed in the G0 phase, that is the clonogenic phase, and they do not multiply and they do not multiply, remain silently, and that become the radio-resistant as chemo-resistant, and these are the cells responsible for for a recurrence of a tumor. They are again resistant tumor, a resistant phase. So the late and early responding tissues, which I have already explained you regarding this. Now, regarding the accelerated repopulation that Whitners had explained and his colleagues explained in the head and neck cancer, the clonogenic repopulation in the human cancer, acceleration occurs at about 28 days after the start of fractionated regime. Like after 28 days of a prolongation of a treatment fractionation, an increment of a dose 0.6 gray per day after 28 days is required. That was the basically laid the foundation of concomitant radiotherapy in head and neck cancer because of accelerated repopulation. So the conclusion is better to delay the initiation of treatment than to reduce delay during the treatment. If overall treatment time is too long, then effectiveness of late dose fractionation is compromised because surviving clonogen cells may trigger into rapid repopulation that I have already explained. And the same is applicable for in a chemotherapy that irregulation in a chemotherapy cycle. If you given a one cycle and then irregular, then that you are encouraging basically accelerated repopulation. So that giving a one chemotherapy and then start radiotherapy is again dangerous in the head and neck cancer, which has been proven that you must go for 2-3 cycles minimum to start the after that you can start radiotherapy, because that will also lead to accelerated repopulation if you given a one cycle and start radiotherapy. There is evidence that some human malignancy radiotherapy produce poor result if preceded by NSAT due to accelerated repopulation. So multiple fractions per day was hyperfractionation. Advantage of prolongation of treatment is to spare early reaction and allow reactionization of tumor, which have explained in the radiobiology portion. However, the excessive prolongation allows surviving tumor cells to proliferate during the treatment. That's happened in the hyperfractionation accelerated treatment. You see the hyperfractionation, and then you increase the number of fractions by decreasing the dose per fraction and increasing the overall dose. So, which I'll explain you in that there was explanation in the European Cooperative Group in head and neck cancer. Then if we increase the total dose in 80.5 gray in 70 fractions by giving 1.15 gray, 2 fractions per day with a spacing between the 6 hours between 2 fractions, in compared to 70 gray in 35 fraction conventional regime, local tumor control was improved from 40% to 59% and reflected in improved survival. And no increase in the side effects. But was the flexor dose, the concept introduced by Whitners and his colleagues, they introduced the concept of DF flexor dose, defined at the point at which the dose response curve start bend significantly because of accelerated repopulation against saved. In practice, curve bends at the dose 1/10 of the at which the linear and quadratic components are equal. So, for alpha beta responding tissues, like early responding tissues 6 to 12 gray, so flexor dose would be 1/10, means 0.6 to 1.2 gray is required. And for alpha beta ratio for a late responding tissue, if it is 1 to 5 gray, then flexor dose for late responding tissue is required 0.1 to 0.5 gray, like a late responding spinal cord, lung, kidney, prostate. So for hyperfractionation regime, dose per fraction cannot be less than flexor dose, because surviving fraction of the cell, if total dose is less than flexor dose, is required. The accelerated treatment using a fastest growing tumors aims to give a total dose in a short overall treatment time with a tolerable acute toxicity. They have experiment, but there was no survival advantage appear, and then increased mucositis even head and neck cancer it was practiced, and the severe late effects. So you can see in this chart continuous hyperfractionation accelerated radiotherapy The study carried out by the Mount Vernon Hospital, and where the 54 gray was given, 1.4 gray to 1.5 gray per fraction dose was given, and given 3 fraction a day in 36 fractions. The strategy was based to the low dose per fraction to minimize the late effect in a very short overall treatment time, to also take care of a fast growing proliferating tumors. But it was observed there is a increase spinal cord myelopathy occur in this study, because probably the fraction time between the 2 fraction was not sufficient to repair the sublethal damage in the spinal cord is a late responding tissue. So you can see here the standard 5 fractions per week, hyperfraction, 6 fraction per week. The chart, you see the 54 gray in 12 days only. And there is another entity, teapot, every tumor having a potential tumor doubling time. The tumor is divided into fast growing tumor, those who having a tumor doubling time less than 4 days, and the slow growing tumor, those who having a potential tumor doubling time more than 4 days. These also we can categorize like a local control of a tumor, like a rapidly growing tumor if lost if overall treatment time is too much prolonged, since rapid growth does not occur for, like in case of a breast, prostate, tumor doubling time is different, like 28 days and 14 days respectively. But in case of a head and neck cancer, tumor doubling time is 4 days. Thus in the breast and prostate cancers, overall treatment time is not critical, but surely in head and neck cancer, overall treatment time is critical. So the Jack Flower linear quadratic model is being explained here, that you see here the alpha, a linear mode of cell killing, and then beta, the quadratic mode of cell killing, and with having a shouldering effect, and a dose is plotted against the effect, number of fractions, dose per fractions, and then you can, by the formula, effect is alpha and d, 1 plus d by alpha by beta, that you can calculate the biological effective dose for every tumor by this formula. So the BED is a parameter by which the different fractionation protocol can be compared. We know though for alpha beta ratio and then of a late responding and early responding tissue by which we can calculate this thing. Thank you very much.